Perfect. Well, welcome. Thank you everyone for joining us today and taking time out of your schedules to participate. Wherever you are in the world, good morning, good afternoon, good evening. Thank you again. We always enjoy having this, and this is our first time hosting a Rural Nurse Q&A. So we want to extend our gratitude to Trish for being willing to open herself up and share with us what it's like to live and work in a rural community. We have heard from many people, specifically our student participants, that getting some tangible real life experiences would be a great benefit. So thank you. Thank you, Trish, for doing this for all of us.
You're welcome.
Just before we get started, a little bit of housekeeping. Since this is a live interview, we have cultivated a lot of the questions in advance to allow for a fluid conversation. That being said, we're confident that during the course of this discussion, there will probably be more questions that arise. Please feel free to use the chat feature or the Q&A feature in your Zoom panel at any time if you have a question that is something that you would like to share with Trish. We are going to be holding it to the end, but please feel free to use that at any time. So before we move forward, I think it would be important for us to introduce Patricia Gilley, Trish, our presenter today. So for over 10 years, Trish has served her hometown of Rockingham County, North Carolina, here in the United States, where she facilitates access to medical and mental health services for residents who are struggling financially. She helps residents access services for food insecurities, transportation needs to appointments, medication assistance, housing, and health education. Trish attended school in Virginia and has been a registered nurse for over 36 years. Her experience includes working in oncology, cardiac rehabilitation, and in a cardiac intensive care step-down unit. So before we turn everything over, what I wanted to do is just give a general overview for people who might not be familiar with where Trish is joining us from. So Rockingham County is this little yellow square right here on the United States map. You can see that this is the Atlantic Ocean. We have Washington, D.C., New York, Philadelphia. So North Carolina is in the southeastern part of the United States. And I think it's fair to say, Trish, that Rockingham County is probably towards the northwestern part of the state. So this is where we're coming from today, to give you frame of reference, which is always important for our global partners. And I'm going to go ahead and stop our screen share so we can start the discussion. So hello, Trish. How are you today?
Hi, I'm fine. Welcome, everyone, and thank you for having me on today.
Oh, we're so grateful that you're here. So before we get started with some of the questions about the rural nursing experience, perhaps you could share with us a little bit about the area that you work. We just looked at the map. So if you could give us a just perspective of what the population and the demographic is like in your area.
Okay, so Rockingham County, North Carolina is considered a totally rural county. It is about 573 square miles. It's predominantly in the Piedmont of the North Carolina, where have the mountains on the western side and we have the coast on the eastern part of our state. So we're kind of in the middle and up to the north, like you said, Stacy. So as far as demographics, population of about 92,000. Out of that 92,000, a little over 3,000 people, about 70%, well, let's see, I'm going to back up a little bit. Under the age of 18 is about 25%, and greater age 65 makes them about 25% of our population. Demographically wise, as far as race and ethnicity, about 76% are white, about 19% are Black African American, and about 6.6% are Hispanic.
Okay.
Yeah.
Now, with respect to the geography of Rockingham County, are there any geographical challenges that you experience that make caring for your community any more difficult than normal?
Yes, since it's an entirely rural community and county, transportation is huge for a lot of patients to get to places because it's a lot of farmland. We do have towns. In the towns, we do have what's called public transportation, but it's only within the city limits of those towns. So if you live out further outside of the city limits or the towns, then it makes transportation more difficult if you do not have a vehicle or someone that can bring you in.
Okay, yeah, that makes sense. So shifting gears a little to the clinic that you work, can you give us any details about to kind of frame that out to give people who a little bit of a picture of what it's like there?
Okay, so I work in a center it's a dual purpose. It is called the Clara F. Dunn Community Health Center. Through the Clara Dunn Community Health Center, we can offer virtual visits. There's no physician here, so we're not seeing patients coming in every day for medical needs per se to see a physician or an advanced practice provider. We can do virtual visits with our patients, and through that virtual visit, they can have one visit through one of the health systems in our area called Home Health. And that is without any charge for that service, and that's until we can bridge them to get them connected to a primary care provider. The other part of the office is called Care Connect. Care Connect is a service that's only for Rockingham County residents, and we service those that are 200% or below the federal poverty line that have no health insurance. So in Rockingham County, there's about 3,100 people that are uninsured.
Wow.
And yeah, so and currently in our program, we have about close to 1,000 people enrolled. And that's with currently a 4-person staff working. We have 2 enrollment specialists. I'm the only RN here, and then we have an LPN and we have a volunteer.
Oh, wow.
So I think we provide a lot of background. So when they come in to enroll in our program, then we connect them we have a network of safety providers. We have a federally health qualified service in Eden, North Carolina. That's the James Austin Health Center. We also have the health department that is here. And then we have another clinic that's a free clinic that's within the Reedsville. So it kind of spreads across our county a little bit so that patients that choose, they have a choice. So they get to choose according to their location, according to what fits them. So it gives them a choice that they have not had in the past. The other thing that's unique about our office is we have a food market or a food pantry housed within our office. So, and I can tell you more about that later, or we can tell you more about that now. But anyone that comes in to enroll in our program, we assess them for social determinants of health. And so we try to address as many of those as possible when they're in the office. If they come in and they have food insecurity, they enroll, they come right back and are able to take so many pounds of food according to household size. And they can come back every week if they need to.
That's incredible. Wow. Thank you.
You're welcome.
Can you, so as far as access to a hospital or a critical care unit, can you give a proximity about how far away you are if you have a patient that comes in with and presents with an emergent situation?
Okay, so we are rural. However, we do have 2 community type hospitals that are under 2 different health systems. So the closest one to the clinic that I work in is It's probably not even 2 miles away. It's a 15-minute
Okay.
drive. However, it was a community hospital, and it's the maximum census at any time is if they're at 50 patients
Oh,
admitted, they're high census. So it's listed as like a 110 bed hospital. They do have a small ICU, but usually if anything is critical, they stabilize them and shift them to a more urban type trauma type hospital. The same within the other part of the county. We have a hospital that's under the UNC Chapel Hill system, and they do the same thing. They can ship them to, with life flight to other area hospitals that are larger and handle uh,
thank
patients.
you. So now that we have a decent visual of not just where you are, but where what your background or what your clinic is like, can you, I know I read your bio before, which is impressive in its own, but is there anything else about your background? I know you have a beautiful story that you might want to share about your experience or your nursing path.
Okay, so I've been nursing now for 38 years. As Stacy mentioned, I went to school in Virginia, and actually my education started in one of the last diploma degree nursing schools, which was a 3-year program that we went to school around year round to graduate. So I actually worked in Virginia for a year at that hospital and was an oncology focus. So that's where my oncology went in. So, but then for 22 years, I worked in a more urban hospital with Cone Health, and that's where I had my cardiac experience. I left there in 2008 due to an injury to my back, and really didn't work for about 4 years. So then around 2011, I started working in the community and have been working for 12 years out in the community. And it's the best thing that ever happened to me. I really love working out in the community and have a passion to serve those in my hometown that have a lot of needs.
I don't want to hit pause on this for a second, only because we have somebody that says they're having a difficulty hearing. So is anybody else having trouble hearing us on the call today? We want to make sure we clear that up so that way you can get the benefit of hearing the full interview. No. Okay, well, if you are at any point in time, please feel free to use the Q&A or the chat to alert us to that. We will do our best to speak a little bit louder so that way everyone has that opportunity to hear everything that's happening. Okay. So can you share with respect to your background, did you fulfill your nursing education and your training with the intention of becoming a rural nurse, or is that something that just sort of happened naturally?
No, actually the school and the hospital I consider more rural. However, that wasn't on the forefront of training 38 years ago. It wasn't really talked about and trained about going out into the community and doing things like that. So no. And then the rest of my time before working in the community, I was in the hospital. I like to share that now I have it's been a blessing actually to see the other side in a hospital. I think they're doing much better than they did when I started working in that hospital in 1986. But it was basically patients were given these labels, which I hate, the label of noncompliance, especially with cardiac patients, renal patients, those type of patients that come in frequently to get tuned up, like I like to say. But the questions were thrown out. Why are they not on medications? Why did they not just take the medications like we prescribe? Why did they not follow up with their care? And then when you see the other side of the picture, they probably could not afford all those expensive medications. Most of them could have been uninsured. They could have been having housing insecurities, food insecurities, and they had to choose between having a place to live and food to eat than paying for those medications. I guess in my storytelling part, I kind of told how it just fell into place, how I came into community nursing. Like I said, I was injured. I injured my back and could no longer do bedside nursing and was kind of like, I don't know what I'm going to do next. And through a lot of contemplation and meditation, it just everything kind of fell into place with a program that is, some may know it as parish nursing and some may know it as congregational nursing. But I started researching and seeking out programs so I could get trained and you have to do a foundations course to become a parish nurse. So I started that and just started looking for ways, because I knew that my community had a lot of jobs had left the community. It was a big agricultural county, and tobacco. A lot of people relied on tobacco. So tobacco started going away, and then a lot of textile plants, and those were closing down and moving overseas and doing other things. So I knew that there was a lot of need and a lot of people that were struggling in my hometown that I had grown up in. And so it just fell into place that things lined up. There were grants that opened up and they asked me to come work. And so I started working primarily in like 2011 with homeless population. And so I was working within the homeless shelter and soup kitchens and things like that. And it has just progressed into other roles as they opened up. But it's just it's the best thing, because you can help be an advocate and be persistent and a fighter for these patients to their voice to be heard. So I love it.
I'm going to take a quick sidebar and just share with everybody listening that what Trish was referring to earlier. Last year, GRNEN conducted a storytelling series, and Trish was kind enough to be a part of that. If you haven't listened to her story, I highly recommend taking a few minutes. You can find it on our YouTube channel, which you can get through our website, grnen.org. It's a beautiful story. So I would definitely recommend taking a couple minutes to participate in that. So sorry to get off topic quickly, but can you, in your opinion, coming with your background and your training and where you are today, can you share a little bit about if you feel how important would it be for a rural nurse to have acute care experience? So, for example, is working in a non-acute care setting critical before you start in rural nurse? Is there advantages to that? What's your opinion on that?
I think there are some advantages to having some of that background. Do you need to totally have that acute care setting? No. I think it's your comfort level, and when you come out, your assessment skills and knowing what your backups are if you get into a situation that you're not comfortable handling, or you need to progress that person urgently to a hospital or to another physician, or have someone a backup. I do have a backup. I do. Here I have other nurses that I can call and run something by. I also have a medical director that I can call him at any time if I need to run something by him. And of course, our hospitals are close by. But I think the main thing is to have a passion to want to serve out in the community. And I think there's a huge need. Even if you decide to go into an acute care setting, I urge you to at least volunteer out in the community that you're working in, or that is your hometown, wherever you live, because there's a need out there. You know, find someone to partner with, find someone that's already doing that and say, hey, can I come alongside and can I volunteer? But I don't think it's absolutely essential to have acute care setting. It did help me in ways that to quicker assess situations sometimes just from the experience. But I don't think it's critical. I don't think it's critical at all.
So you mentioned your backup, that you do have a backup as a rural nurse. And I know that was one of our questions that we were asked, is what sort of backup do you have? And then I'm sure it's different everywhere. But it's interesting that you brought that up then, because there were quite a few people who asked, like, when you're working in a rural setting and when you are in a rural community, oftentimes there isn't a physician at your clinic. So, and you, as you mentioned earlier, you have a small staff. So what happens if you are tied up or you need assistance? Like, what kind of backup is in place for you?
Okay, so I've had some situations where, well, for one, we have the virtual care, so we can call in and do a virtual visit. However, that's a limited scope of practice. But if you think that you're in a critical situation, of course, there's 911. But I always know that I can call my medical director. He works for the cone system, has been a critical care physician, and I can just tell him what the assessments are and what does he think. And he's very gracious to do that. I also have two of my supervisors are also nurses that I can call at any time and bounce ideas off of. But I never hesitate to get someone to the hospital if they need to. But I think it's important to have that plan ahead of time before something happens, and know what your protocols are going to be. We do have resuscitative equipment here. We have a defibrillator in our clinic. We do provide some what we call point of care testing. So we can do blood pressures, temperatures, oxygen saturations. We do have an ambu bag. We do have, we can check glucoses, and we can do an A1C and some other minor things. So we can do those first things that we need to do while we're away transport if that's needed. The most urgent things that I've had here happen when actually more mental health. That's when someone comes in and they're actively suicidal.
Okay.
And that is definitely to have a plan in place and know who to call for mobile crisis, and just have a good background in knowing how to just stay with that person. Because here, mobile crisis can take up to 2 hours to respond.
Wow.
To on scene. Now, sometimes they will talk and assess the patient virtually, or they'll ask you to wait with them and keep them safe until they arrive and determine what the next steps would be. So yes, knowing your plan and having it all written out if you're going to be out, knowing who your backups are.
Yeah, that's smart. Thank you for sharing that tip. So when a couple of moments ago too, you were also talking about about working as a rural nurse in your hometown, and how you encourage people to, even if you have the opportunity to go back and serve in your area. Now you have been working in your hometown. So can you share a little bit about what the advantages are of serving the community you live in, and if there are any challenges in that as well?
I've seen nothing but advantages. There could possibly be some disadvantages, but the advantages that I see are that you're already trusted within the community because you're not coming in from the outside. There is some type of commonality that you can find. It's just it's a small area, so people, they know when you're from here and they know when you're not, and it's a trust issue. They're more would open up a lot better if they trust you first. We noticed that when we first started the programs here, a lot of the patients, we went out all across the county and just polled people and just kind of did a ride around in what I call a dashboard view, and just look around and see what's going on here. look for signs of homelessness, look for signs of more disparities and social determinants that they have needs for. And a lot of people said that they were cautious and not trusting of people coming in that come in and tell them, you need this, you need that, you need this, you need that. They would rather for you to sit down, have a conversation with a group, and then to share with you what they feel their needs are and what they feel would benefit their area. Because we're a one county, but we have small little communities. And those little communities can be pockets and can be very, sometimes cliquish in their own ways. And they just are leery of people coming in and telling what they need instead of sitting down and having that conversation. So I think that's very important. It's an advantage that, some people recognize my name and, hey, you're so and so, and hey, my son went to school with you, and you form those relationships. So when you're out working in the community and you come up with a need that you do not have a resource with, if you built those trust and those relationships, you can pick up the phone and call a church near this person and go, hey, do you have a resource to help them get a ramp built so that they can get safely out of their home and to their doctor's visits? Yes. So I think it's a great advantage. Disadvantage would be living, if you'd have to be really good at setting boundaries. And I'm kind of learning this more because as caregivers, nurses, we tend to not shut off caregiving. And if someone approaches us when we're not at work or we're in our faith community trying to worship, we're more than likely going to answer their questions or help them because that's just who we are, right? That's what we're passionate about. But you do have to have those boundaries and have that work-life balance. Because you will get burnout. You do see a lot of sad situations. You do see a lot of people with a lot of disparities and a lot of needs, and you have to have that time away to recharge.
Right.
Yeah.
That's so important. So what would you say is the hardest part about being a nurse in a rural community?
Oh, not being able to find a resource for something that is truly a need. Just for instance, just something that just happened this week. Had a referral from someone who had been discharged from the hospital, congestive heart failure, atrial flutter, had to be converted, had a mechanical valve that needed to be on Coumadin and be anticoagulated. When I called to follow up with her, she was discharged on 12 medications. No assistance given before discharge. It kind of fell through the cracks. So this is 3 days later, she hadn't taken any of her medications. So we were able to help find a resource to help because they were like $150 for all those medications, and she had no income and no insurance. So we were able to help her get that, then get her appointments to get her blood work drawn so they could check her levels for her anticoagulation, get her transportation to that appointment because she didn't have reliable transportation. Now, the offset of that is you have to prepare for, you always can do your best and get all these resources set up, but sometimes the patients, for whatever reason, do not follow through with those. And so the situation was she had transportation waiting on her, but she did not come out of the house to go to the appointment for whatever reason. And that's going to be a deeper conversation. We don't know what's going on inside the home. But so the biggest thing is resources. I wish we had lots of pots of money, but I've noticed that a lot of people that are working in the rural communities, a lot of programs are grant funded. So there's always that hanging over your head. Are your grants going to be renewed? Are you going to be able to sustain the program? How do we educate the patients that we're working with? So if our program is shut down, will they be able to continue to stay healthy as possible and to continue their care. So I think that that's one of the most challenges for me. And the other would be you just see a lot of sadness, you see a lot of heartache, and it's hard to turn it off and to go home and not worry about our patients and are they going to be okay. It's not very evident when you drive through our county like you would in a very urban city, but we do have a lot of homelessness. So I have patients that are living in tents and woods. I have patients that are living in outbuildings, abandoned buildings, cars, things like that. They're yes. So it's hard. That's some of the hardest things for me anyway.
Sure, that's a lot to carry. It's a lot to carry on top of the day-to-day work and personal experiences that you have in front of you. So this might be a challenge. I would imagine it would be a challenge for anyone in the medical profession, but especially in rural. Are you able to share what a typical day looks like for you?
So,
If there's a typical day?
I mean, you kind of come in and be prepared. I mean, you have in your mind what you're going to plan for the day, but usually your plans change. So it's just kind of whatever walks through the door, you have to be prepared for. So um, anyone that comes in and enrolls in that Care Connect program that gets them access to care, we offer a nursing assessment. So it's myself here, and we also have an LPN. So whichever one of us is available, we will provide a nursing assessment. If we need to do a virtual visit, say they're out of medications, and we want to bridge them with medications until they get seen by a new primary care provider, then we do that virtual visit. A lot of education and case management. Here in our program, there's two factors that we look at with chronic disease, and one is diabetes and trying to lower A1C. So that's kind of on my plate, and anyone with an A1C in our program that is 9 and above, I try to follow up with those, educate those patients, and try to get them into programs to help lower those numbers and get healthier. The other thing is hypertension, which is a big factor here in our county. And Wilhelmina, which is the LPN here, we do a remote hypertension monitoring program.
Okay.
So through some grant funding, we were able to get some Welch Allen equipment that is Bluetooth. So they get a scales and a blood pressure cuff, and we get them set up with the app on their phone, and they weigh and monitor their blood pressure under certain guidelines, and then we can send those results to their physicians for follow-up and treatment evaluations and changes as needed.
That's interesting. That's interesting.
And a lot of my day is on the phone, following up with patients, doing case management, seeing how their first appointment went. I follow up with everyone within 24 to 48 hours of their first patient visit, just to make sure that they don't have any questions about new medications. Do they need help getting those medications at first before they're approved for some medication assistance programs? Do they have any questions about their lab work? Do they have any questions about what the physician or the provider told them? So we do a lot of follow-up calls, and we try to follow up with all of our patients at least every quarter, but there's some that we follow up often, some every day, some every week. It just depends on their level of need.
Okay. I think this is maybe the perfect follow-up question to that. If you could describe a day when you felt you made a difference for one of your patients. I'm sure there are many, but out of some of the sadder stories, can you share one of the happy ones?
Oh, absolutely. Okay, so about a year ago, we had been working with a patient, and she had gotten access to care. She did have some mental health challenges, but she was working through those and doing well. Then some things changed in her life. She lost a son. So she fell back into addiction. Through that addiction, she kind of lost track of her health care. She became homeless. She was living in her car in an area called Market Square here uptown, and sleeping at night in a doorway uh, and outdoors. So was able to follow up with her and get her connected to a shelter. It was actually closed because we only have a winter emergency shelter,
Okay.
and this was summertime.
Oh, okay.
So, again, the relationships formed. So I had been the nurse at the homeless shelter, so I knew the director. So I gave her a call. Is there any way we can get her in out of, because she wants to try to go into rehab. She's going to the library and filling out applications. Is there any way she can come to the shelter to stay while she's in this transition? And she did. She took her in and let her work and clean the beds and cots and help clean to get ready for the winter shelter time. I had not heard from her in a while. I had called her a few times and her phone was disconnected, or she didn't return calls. So about a week ago, I was doing what we have a list of patients that are currently enrolled and another list that are called MVPs. And MVPs were people that might have been a year ago were high utilizers of the emergency room. And I looked and saw her name. It's like something told me, I just want to follow up with her.
Right.
So I called her and she didn't answer, but I left a message. And she tried to reach me over the weekend. Again, boundaries. So did not respond to her till Monday. And she shared, she was so thankful. She had gotten into a program, had been in a rehab program locally for about a year and was about to graduate next month. She said that she had just talked about our program the day before and was telling everyone how thankful she was that we were with her in the beginning, stayed by her side even when she was not at her best. And now we're calling and checking up on her to see how she's doing now. So she invited us all to come to her graduation next month. She's all excited. She's entering a graduate program. She connected to another program like Care Connect in that county, which is called the Orange Card. So she's been getting medical care. She's been working. She was able to save money from the job she was allowed to work at to pay off all her parking fees and vehicle fees. So she'll be able to use her vehicle when she graduates. And it was just, she was crying. I was crying. She's just scared that she has a whole new outlook on life. And
Wow.
it was just wonderful. So.
That I have, that's amazing. That's amazing. And I'm sure going back to what you said earlier about the advantages of what you do, you know, as a rural nurse, you get to see that. You get to care for this individual and see them through to that other side, where in an urban center or critical care, you may not, you likely won't ever know when that person walks out of your doors how they're going to fare a year from now. And here you are going to have the opportunity to see her graduate. That's incredible.
That
Wow.
is the most advantage. We get to see them get healthier, get better, feel better.
Right. Wow. So I know you talked a lot about the different disparities in your county. Can you share a little bit what the greatest resource needs are for your patients?
Yes, I think a lot of the same needs across all boundaries, but housing is huge. Trying to get someone into housing that, I mean, they're homeless, but they have no income. They're not disabled. So, you know, that disability income's not there. So it's kind of a process. And plus we do not have a lot of transitional housing at all here. And like I said, the homeless shelter is nighttime only through the winter months. It starts December through March. So there's nowhere for them to go during the day, but either back to the streets or the tent or wherever they choose to to go. So that's huge. Transportation is another huge barrier to care, because some live in the cities where they can do a bus route and some do not.
Mhm.
So trying to get them transportation, and that's been a huge thing. We had a program that was working very well, but it wasn't generating any revenue. So things had to change, and so the transportation that we're providing now is coming out of our budget, which we're on a tight budget for grant funded. But
Right.
it does help patients get to those appointments for primary care. The other need is a lot of specialists that our patients need are not within this county.
Okay.
So, for instance, they have to travel out of the county to see a neurosurgeon. And some of our patients have had to travel as far as Chapel Hill, which, to give you some idea, is about an hour and a half away
Okay.
from this office and most locations in Rockingham County. So to pay for that transportation, to give you an idea of the cost, that's about $350 round trip
Oh, wow.
to get someone to Chapel Hill and back home.
Right.
So yeah, and then there's just some specialists that we just do not have resources for.
Right.
So,
So I'm sure all that goes hand in hand with there's so many challenges in rural, as you're saying, with access to resources, access to equipment, access to advanced services, workplace shortage. So it's all kind of feeds back into that situation.
absolutely.
Wow. So as you look towards new graduates who would be seeking employment in rural, I know you've described your personal advantages. Would that be the same if you were talking to a new graduate and they were contemplating going into critical care in an urban environment versus working in a rural setting? What would you say to them?
I'd say both are great and both are a great asset to have. However, if you really, you really have a passion to go out into the community and help be an advocate, the voice of the people who have not been listened to, who have not been heard, have been marginalized, who have been underserved. And just like today, we had someone walk in, I just can't get care because I have no insurance. Somebody wants to help me. Well, yes, come on in the door and sit down, because that's what we're here for. So yes, I mean, I encourage you, if you really want to do critical care and you want to work in a acute setting, do that. But I urge, volunteer, give of your gifts and your talent out into the community, and I promise you, you will be rewarded 10 times over.
I'm sure. Are there any characteristics or qualities that you think are necessary to work in a rural setting that are unique to an urban area?
Probably some of the same characteristics. A lot of patience, because it can get frustrating when you're trying to say, okay, you really need to do X, Y, Z, and you help them break down any barriers to X, Y, Z, but they still do not move forward and access those things. So a lot of patience, a lot of persistence, a lot of just people skills. I think good interviewing skills, because they've told their story so many times that they just are not going to tell you again, because they figure no one's going to listen to them, no one's going to hear them, and there's no way they're going to get help. So when they come in and say, you have a choice of your provider, when they thought they had no choice whatsoever, yeah, a lot of times you have to earn that trust and earn them to be able to open up to you. So I think, yes, so be genuine, just be down to earth, just be able to sit and take the time. And that's another advantage out in the
Right.
community. this is what I love about working at the community. If I need to sit with someone for 1 hour and listen to them, listen to what they have gone through, develop a plan of what we're going to do, I can do that. When you're in an acute care setting, you try to do that, but you can't. You
Yeah.
can't. I mean, there's no way. It's too much going on. So that is the greatest advantage, and try to take care as much as you can when you're sitting with them, because tomorrow their phone might be off, or yeah,
Right.
it's in their
You have to
hard to reach. So
take that opportunity while it's available. And it's nice that you are empowered to do that.
So I like to say that it's, I mean, not that practicing in a facility is not, practicing the art of nursing, but I think being out in the community and being able to take that time, not only to relate to the patient that you're working with, but their caregiver or their mother who has been trying to get them into rehab and she's fallen apart, that you can serve the whole family and just look at the holistic approach and the whole person and what all they need. It's just, I encourage everyone to try it. Like I said, even if you just volunteer, you find a program in the area that's doing some ministry or missions, or, um, come to Rockingham County, I'll put you to work.
There you go, right?
Right.
Well, we're coming close towards the end of our session. So before I take up too much more of Trish's time, I want to open this up to our participants. And I know we've got a lot of incredible information that was shared today, some really powerful stories. So if there's any questions that you have that you would like to ask Trish, please, this is a great time for you to use your chat feature or your Q&A, so you can directly ask. And I will be looking at that. Also, I know that everyone's time is challenged. So if you have a question that you might not think of in the moment right now, but later today or tomorrow, is something that you might be curious about, either from a practice perspective or specific to what Trish is doing and where she is, I'd like to remind you that you can always connect with Trish through our portal on the GRNEN website. She is a member. You can ask her any question through that, and I'm sure that she's always generous with her time. So you can always feel free to do that. One of the questions that I'm seeing is, you earlier in the beginning of the webinar, you had mentioned that you have a decent Hispanic demographic in Rockingham County. So do you find that you are challenged with a language barrier when you're treating individuals from that community?
Absolutely. We do have some tools and some things in place. We do have the interpreter line that we can use on phone calls or when someone's here. We also have an iPad that has a program called Stratus that we can pull up lots of many different languages and use it as a video, or it can be a phone call. But the greatest thing, that asset that we have, and I use a lot with the patients that I follow up with, we have a bilingual interpreter who is medically certified. She works full-time at Women's Hospital with Cone Health, but she volunteers in our community. She's from here, so
Okay.
she is well trusted within the Hispanic community, and she does a lot of our Hispanic enrollments. And I will utilize her and call her and say, "Hey, Milena, can you please call and tell this person they really need to go get that lab work done? They really need to, can they come in and talk to us?" And she's flexible because she does that on the weekends, and that's been the best time for that population, because they work a lot during the week.
Sure.
To be able to meet them. So I will take a day. It's usually set up where they let me have 1 day a month on the weekend, and I'll go work with her, and we'll do phone calls and follow up with people, or if they come in to enroll and have a need, then we discuss that. So a great thing that's come out of that is I did share that I'm working with Hispanics. So a thing that really bothered me is a lot of diabetic education is just cookie cutter. It's like, don't eat biscuits, don't eat potatoes, don't eat.
Right, right.
It wasn't really culturally sensitive to the foods that they eat.
Sure.
And we were able, through Melena's contacts, a health coach who was in the dietitian school, who is bilingual. She's from Mexico. So she was able, we set up a group of our patients came in on a weekend, and she was able to have a dietary and nutrition class with them
Oh,
in
wow.
their native language, and talk about the foods that are common to them and how to do that. And it was great. They really loved it. They really related to it well. And so within that, we have another grant funded program of getting scholarships for some of my patients to the Y, to be able to use the pool and other things to get healthier, and more of the agencies. 3 right then decided to sign up for it. So yeah, so I think it's helpful to have those language lines, but it's also, I think, more helpful to have someone who is bilingual, as a native speaker, and trusted within the community, because there's a lot of mistrust for many, many reasons that we won't get into, but
Well, that's great. I mean, and right there, between having you and having that individual, as I'm sure your other colleagues too, that helps cross a lot of those hurdles.
absolutely.
And another follow-up question received is, you are talking about the experience of homelessness and how there are so many individuals in your county that are living in tents in their cars and abandoned buildings. And a big part of your role and your clinic's role is follow-up. So is that a challenge? How do you follow up with people who don't have a permanent residence?
So we will go out to where they're at. What I do primarily is, when they have an appointment at their primary care provider, I will make time on my schedule to be there and meet them at their appointment.
Wow.
So it's a little bit easier. Can follow with them right away if there's any medication changes and things like that. But we also have another wonderful program. It's an integrated healthcare program, and it's community paramedic program. And they are also grant funded, but they have community paramedics that will go out, but they also have a social worker that's attached to them. So a lot of those we do risk stratification. So anyone that's homeless is automatically high risk. We refer those to that program, and they do a lot of going out, because they can go in pairs, and they go out and help them apply for housing. They help them apply for disability, Medicaid. Of course, we help with, they can help with food stamps. We can do that too. But being a social worker that works through DSS, he's more familiar with all the ins and outs of, applying for Medicaid and disability and those types of things. So it's a great resource, and we work together, and they call and follow up with me. Hey, we need this. Do you have that resource? And I do the same with them. How's it going? What are their challenges, and what are they doing? So it's a good situation.
So if there aren't any other questions at the moment, I want to take a quick second. I know we're closing on the top of the hour, so I really appreciate everyone sticking with us on a Friday. And I hope it is as beautiful where you are as it is where I am. So on my screen, I just want to share this. It really ties back to a lot of what Trish was saying. We've been conducting a mental health series this year, and it's both in recognition of sharing overcoming and helping mental health situations in your community. And also, if you go back, what we did last year is caring for yourself as a nurse, a healthcare provider who it's very hard to draw the boundaries that Trish was saying, and it's hard to turn it off, and it's hard to, you carry so much with you. So next month we have Whitney Fear, who's going to talk about cultivating emotional wellness in rural communities. We have a few others, mental health promotion, psychosocial support in August. And that one it was interesting fallout from the gentleman, Mario Dimapalis in the Philippines. This was a program he conducted during COVID in order to help continue to reach his community during lockdown. And his shared experience. And then Charlene is going to be sharing with us in September psychological trauma experiences of rural nurses who live and work in the same community. I intentionally skipped over our July, and the reason I did is because I wanted to focus on that for a quick moment. As Trish shared earlier, a lot of her critical situations come from when people are coming to the clinic presenting with suicide. And on July 13th, Dr. Tamara Kiefner, who is with the University of South Dakota, is going to be doing a training program. If you're not familiar with the QPR training program, the question, persuade, refer, she refers to it as CPR for suicide. And it's how to be able to assess and address and maintain the situation until support arrives. I think that it's going to be a very empowering session for people in our GRNEN community. So it is limited to 35 people, which is why I wanted to kind of focus on that quickly. We will host it again if the wait list gets extensive. So understanding that with what Trish shared earlier, and again, knowing that that is such an important topic for our community and those that they serve, I wanted to highlight that. You can find that all on our website. But we are at the top of the hour. Again, please feel free to reach out to us at GRNEN, reach out to Trish through our website if you have any additional questions. If you can't find her on our website, you can reach out to us, info@grnen.org, and we will make sure that question gets passed along. Trish, I cannot thank you enough for giving us your time today. Your dedication and your service and your passion are just so wonderful. And I'm so grateful that you always share with our community. I think they're lucky to have you. I know we're lucky to have you. So thank you for the time today. And everyone who took your time to sit here and to join us and to be a part of this and to share your questions. Thank you so much. This is why we do what we do. So we appreciate all of your time and efforts. So, thank you, everyone. Enjoy the rest of your day. Enjoy the rest of your weekends and take care. We'll see you next time. Bye now.